Hello.
Hi, Laura. I'm so sorry. I
That's okay.
apologize for the delay. How are you?
Good. How are you doing?
Doing well. It's so great to meet you in person, and really congrats on the BuzzFeed article.
Thank you so much.
Yeah, very powerful.
Yes, I'm so excited to be chatting with you today.
Same, same. So, yeah, do you want to really just tell us about kind of, the thoughts and a delayed diagnosis of pelvic congestion syndrome, and just really, some of the, real life kind of frustrations and, the kind of runaround that was given.
Yeah. So first, let me just kind of introduce myself to everyone, though if they read any of the amazing posts, I'm so happy to see all of you. My name is Dr. Laura Meihofer. I'm a pelvic floor physical therapist. Hello, I love all of the hearts. I'm sure if you all have any questions, you can shoot them in the question box, and Dr. Allyson and I can cover them. So what Dr. Allyson is referring to is I was featured in a BuzzFeed article that specifically talked about pelvic congestion syndrome, and it was I was asked to be an expert on it after a really amazing woman shared her experience of going around and around and around for the last year trying to get a diagnosis. And actually, I have a patient that's going to be coming to you in the very near future, Allyson. So you will have to keep your eyes peeled for someone similar who has been getting the runaround. So basically, and please jump in if I say anything incorrectly, pelvic congestion syndrome is when we have to our ovaries and uterus increase blood flow because the veins will get backup and pooling of blood flow, and similar to varicose veins that you might see in someone's legs, the same thing can happen around their uterus and ovaries. Did I get everything correct with that?
Yeah, no, 100%. It's definitely, yes, it can be complicated. The old terminology was more pelvic congestion syndrome. They're now starting to call it pelvic venous insufficiency, but that's exactly right, where essentially there is venous pooling. So the veins aren't kind of draining like they should back up.
Yes.
Heart, and that venous pooling will put pressure on the pelvic structures. The pelvic nerves particularly can be very irritated, but also the fascia, the muscles irritated, and any of the organs. So it's that extra venous pooling that puts a lot of pressure on everything, which doesn't help.
Right. And so just as you were saying, that extra pressure can feel like a heaviness, a dullness. It, like you were saying, with the compression on the nerves, people can have abdominal pain, pelvic pain, vaginal, rectal pain. There can even be pain with intercourse. There can be urinary incontinence, bowel issues, all of that. And so in the spirit of this amazing talk that Pelvic Rehabilitation has graciously put on, I think it's a huge piece of having doctors and physiatrists be able to work with physical therapists, physiotherapists, because it can be such a challenging diagnosis.
No, 100%. And kudos to you for really helping, the patient get to the needed services.
Yes. So I would say, and I'm really interested to hear, I know you guys sent a bunch of information, and I see we even had a question that said, are you in Palm Beach area at this time to see patients? So I'd love to share kind of how I go through my evaluation, and I would love to hear how you go about yours to do this amazing protocol that you created. And I think that can be really maybe helpful to people to see how similar and how sometimes different it is what we do, and how that helps everyone get better.
100%. Yeah. And
yes,
exactly where you're practicing, the location. So anyone listening if they're able to, you know, come see you for help, that would be amazing.
Yes, thank you so much for that. So I'm actually in Minnesota. I'm about an hour and a half southeast of the Twin Cities. And so I have I've been here and I've been a treating pelvic floor physical therapist for 10 years now, which is awesome. And I offer some remote consultations and telehealth consultations. So kind of every day on Instagram, on my email, I'm fielding from people all over the world. And so I offer that as a way to get people going. And then I also have intensive programs where people can come for a long period of time to get that hands-on care that they need. And then of course, for anyone who can make the drive and see like weekly or every other week appointments is what I offer. And part of that offering is whether not so much the telehealth piece, but there's a lot that I can glean in hearing someone's history, but the hands-on piece, and one of the things that I think is so huge about physical therapy and physicians is being able to assess those muscles. So the pelvic floor is comprised of 26 muscles. It has some I know I'm telling this, you already know all of this, but it has some beautiful nerves that come through those muscles, wrap around and feed into various layers. And like we were talking about with that venous insufficiency or pelvic congestion syndrome, the weight kind of goes on this hammock of muscles. And so what I do is I really look at what is the range of motion and coordination of those muscles, and then I push on gently and palpate each layer and each muscle to see where is their tension, where is their tenderness, and can we create any change.
That's amazing, and that's wonderful. So tell me, what I think is great is how you were able to really come up with this primary pain generator for your patient, because I'm sure, you know, you see multiple diagnoses. What would be the most common that come to see you?
So the most common is, I would say, pelvic pain. And then from that pelvic pain, or even urinary incontinence. But how I kind of quantify it is people will have this tight, tender, shortened pelvic floor muscles. And because they're tight, tender, shortened, they don't get that adequate function. And so when I'm trying to differentiate, love the hearts, between something that is, we need more of a physician to intervene, like pelvic congestion syndrome, versus something more that I'm able to handle, is if my manual techniques, my hands-on techniques are not helping them get better in any way, then we know that we need our amazing colleagues like yourself to see what else can we offer them so that they can get better. So I might offer, besides for hands-on techniques, we do a lot of deep breathing, a lot of behavior modification, like how they're positioning themselves on the toilet, what they're eating, all of that. And when we look at that whole person and all of the things that feed into their condition, and we've kind of ruled out, hey, you're doing such amazing work, but you're not getting better, then that's when we know we need to loop back in and explore something a little different. So yeah, so that's kind of how I do it. And then I always arm my patients with lots of education and information, because as you know, with these challenging diagnoses, a lot of times people are dismissed.
Completely. That's an amazing approach. I love how you're kind of, you know, thinking from the entire perspective of what could be going on here. Hmm. And you think pelvic, you know, congestion syndrome for this particular patient? Were there certain signs and symptoms that you thought, you know, let's refer?
Yeah, so for this for the BuzzFeed article, this person wasn't my patient. I was just kind of speaking in on it. But for the other individual that's coming to you, it is definitely kind of a question in my mind, because So in addition to many of these pelvic congestion syndrome patients and the ones I've seen in the past, they often times have the pelvic pain piece, but they also have, like you were saying, this heaviness. And so as a physical therapist, what I will oftentimes do is I will have them get into positions that can encourage prolapse, because a lot of times they're pushed off as, well, maybe you're dealing with prolapse. We'll do this surgery to I had one person just take out your uterus. We're going to do a hysterectomy because you've got heaviness, even though there was not one indication that they were having a prolapsed uterus. And so I'll get into these positions to like where I'm laying on the ground and they might be standing over me or even getting in a squatting position and using a mirror to see. And if we're not seeing any prolapsing, but they're still having heaviness, if they're able to fully empty with stool and they're still having these symptoms of fullness and heaviness, that's where I start to think, okay, this is not a regular presentation. They're having things that we can't make go away. And then especially if that heaviness goes away when they lay down or elevate their hips. So I have several individuals who were spending a majority of their day laying down because as soon as they stand up, that blood flow pools into the bowl of their pelvis and they're not able to function because of the pain and pressure. So those are things that for me start to say little red flags. And then when we try to do typical strengthening or coordination and it's not getting better, or relaxation and it's not getting better, then you don't need to see someone for a ton of visits to know we need to look deeper at this.
I love it. 100%. I mean, that's exactly the classic patient, right? They say they're standing all day and it's worse, right? Or you go to an amusement park and it's worse, right? That constant venous pooling and the pressure on particularly the nerves. Yeah. And sometimes you can even see some swelling, right? With either in the lower extremities or the perineum or the vaginal area. Sometimes there is a little bit of swelling with our patient population who have pelvic venous insufficiency.
Yes.
That's great. I mean, and classic kind of risk factors, guys, for pelvic venous insufficiency would be, multiple pregnancies and deliveries is probably our common. Where you'd want to for sure consider it. And then we also do see it, honestly, with some history of gynecological disorder. So we do see a sometimes or adenomyosis or fibroids as well. So those are kind of the two most common times we'll see this pelvic venous insufficiency in our patient population. And what's great about it is we're able to diagnose it. It's you can get an MR venogram, and you can get the detailed look at the veins and is there reflux, is there pooling, and then you can refer to either an interventional radiologist or a vascular surgeon.
Now, do you find, do those ways of looking at things, does that change during the month based on the individual? So like if it's a certain part of your cycle, can those results change?
No.
Or show it more prevalently? Okay, so that was a question I got.
Yeah, not typically. It's usually, yes, that kind of venous function it is typically there throughout the menstrual cycle, but that's an excellent question.
Yeah.
We see is that this postcoital soreness other than that heaviness, that achiness, clearly worse with standing, this postcoital soreness is also common. But we see that in a lot of our patients, but it's that postcoital, right? Not always during, it's after. Those are kind of key history things to look for.
Yeah, and what I just find so fascinating working in pelvic health, but specifically working with individuals that have vulvas and vaginas, is how commonly these things are just kind of brushed off and just told, oh, it's your period, or, like the pain must not be that bad. And so that's been something that's been very interesting to me. And also following the BuzzFeed article, what was interesting was reading the comments of people who have missed diagnoses, and a lot of endometriosis people I found in the comments, in addition to the pelvic venous insufficiency. So that's been something that I think is so huge for platforms like ours to help share good information and knowledge.
100%. I could not agree with you more. I mean, that is the key, to just raise awareness, start the conversation, make it less taboo. And, you know, unfortunately, we hear it all day, every day, you know, women really living with it, right? Because they have to, or normalizing their discomfort, whether it's, you know, with intercourse, during, after, that feeling of sensation of heaviness, right? There is, you know, we can get a specialist involved and try to figure out what's going on. I completely agree with you. That really the key is to figure out every patient's underlying primary pain generators, and then address the best we can, right?
Yes.
Just figure out what's going on and then address it as best as we can. So and it always takes a team, right?
Yes.
So
yeah. Now with I know you have 13 like clinics, right? Did I speak correctly with that many clinics?
That's correct. Yes.
Oh, that's so amazing. And what is your preferred way of working with physical therapists? Do you like us to be involved before, after? Because I love hearing from providers on how we can best integrate in with you.
Oh, before and during and after. So, no, I mean, really, it is that integrated team approach that really works, right? That comprehensive interdisciplinary approach that works with chronic pelvic pain patients. Our classic team is always pelvic floor PT, and then Physiatry, we're extensions of pelvic floor PT, right? The version of pelvic floor PT, and then quite often we'll bring in either cognitive behavioral therapy or sometimes nutrition, and then whatever other specialties the case presents with, you know, quite often work very closely with OBGYNs or urologists, who you know we need help with. So it really just depends on the case, but yeah, that's for PT for sure. You know, we have this similar approach with treating that underlying nerve dysfunction in the peripheral nervous system and the myofascial pain and dysfunction.
Yes.
So I'd say we have different tools that we use, but together it's so much more powerful than alone.
Yes, and I think that's the biggest piece of all of these things. And I know many people who have come to me, they think, oh, well, I just have to go to you, Laura. And I always say, no, we've got to have everyone. I don't necessarily have all the answers. And like, I loved how you talked about CBT, I think is so huge with this, because even when you have a real diagnosis of any diagnosis that can be out there, that's pain generators, anything, it's so important to also be working on that mind, the nutrition piece of things, so huge as a component, in addition to all of these other sort of medical interventions.
100%. I think, yeah, it's the data really has shown, and also doing it all at once. What can be challenging for patients is, you know, they've tried one and then something sporadically and not interconnected and not at the same time. So it really works best if we do it all together, that multi.
Yes.
Sure. Yeah.
Yes. Yeah. And I would say for me, being in slightly a smaller community, which Rochester, Minnesota is not that small, but it's relatively small when the cities are only an hour and a half away from you, that it has been kind of that sometimes challenge of getting that buy-in to say, okay, I know this feels like a full-time job sometimes, but I need you to also do your other appointments with your other people so we can get you better.
Completely agree. I completely agree. Okay, there's some
questions.
Dr. Allyson, can you please tell us some information on hydrodissection? What percentage of your patients get better from this? What if an X-ray shows pubic symphysis shift? Can this cause pudendal neuralgia? Okay, so a lot of different questions. Okay, yeah, no, conceptually, the hydrodissection technique, what it means, it's a high volume approach, really, to release fascial restriction. So we do believe that there is some myofascial compression that's going on of the nerves, and of course the muscles are a strong component, but we have a strong belief in the fascia. So that's really what it means. It's working with physical therapy, pelvic floor PT, very similar approach with that fascial release with your hands, the manual technique. It's just a MDDO version of doing it non-operatively with honestly, but it's conceptually a very similar approach to the PT.
Yes, and to also build on what Allyson said, when we look at that pubic symphysis, I always say it's important that when you go, and this leads into a next question that says, how can you find the best therapist? So when you go to a physical therapist, they shouldn't just look at your pelvic floor only. So when I am working with a patient, I actually look at their pubic symphysis to see when I line my fingers up, is one finger higher than the other, which would cause that shift and create that change. Then I follow the pelvis back to where it comes into their sacroiliac joints, and I actually look all the way up their spine through their lower lumbar and then into your thoracic spine. That's super important because the pelvic floor, I always say, is kind of like, maybe this is because I'm from the Midwest, but maybe not. I always think of like horseback riding and a bridle. And so if you are, if your pelvis is shifted, it's kind of like you're pulling the horse's head one way, which can affect how those nerves are compressed or any of those things. So when you're going to a PT and when you're looking for a good pelvic PT, they shouldn't just be focusing on your vagina or your rectum. They really need to expand, as we were saying, and do that whole body approach.
Yes, 100% agree with Dr. Moiner. That's with pubic symphysis dysfunction. If there is asymmetry, essentially the pudendal nerve would be affected because there's some shearing that could be going on, where with something called pelvic obliquity that can be associated with your pubic symphysis dysfunction. So it's really realigning and releasing things so that the pudendal nerve would not be irritated anymore. So that would be the connection.
Yes, definitely. And it looks like it says, how can I find the best therapist? And they're on their third, and they're nervous from past experience. So this is a wonderful question. I like to utilize a couple of online search engines. So there is the section on women's health. They have a PT locator. There's also Herman and Wallace and Pelvic Guru. I have all of these actually on my YouTube channel with a video that explains how to find a good therapist in your area. It's on Laura Meihofer LLC. And then I always recommend asking questions such as, do you have experience treating this? So you can share briefly that you've had 7 surgeries, a hysterectomy, you have adenomyosis, endo, IC, flares, all of that, IC, and you can ask, do you have any experience treating that? So I have many people that I've mentored who maybe only see 1 or 2 pelvic patients a week or a month. That wouldn't be the person I would go to for you. I would want to go to someone who sees a higher volume. So I only do pelvic floor. And so you would want to find someone more like me. Then you can ask if you do internal and external techniques. I'm sure, Allyson, you've maybe run into this, but I always think it's interesting when people say they're a pelvic floor PT, but they don't know how to look at, or they refuse to look at those muscles internally. That seems a little bit silly to me. So make sure that they're going to do that full assessment.
I completely agree. That is, yes, and a very important question to ask. And also the International Pelvic Pain Society.
Oh, yes.
Their website as well is excellent to find a local provider near you.
Yes. It looks like we have another individual that asked about pelvic congestion syndrome in males, and if it has a link with persistent genital arousal disorder.
Yeah, so yeah. I mean, how that would be connected? You said your imaging showed that there was some pelvic congestion. So again, it could be putting pressure on that pudendal nerve, as we described, because of that venous pooling and that pressure down, right? So therefore the pudendal nerve could be acting out, and instead of causing pain, it would cause hyperarousal. So it is still what we call this aberrant firing of these peripheral nociceptors, but it's not causing those the pain fibers, it's causing this hyperarousal effect. So potentially, it could be potentially contributing to your symptoms.
Yeah, and then to speak on the pathology of the spine component for men, at least in my practice, I've seen a huge correlation with what's happening between their thoracic spine and their lumbar spine, known as the TL junction or thoracolumbar junction, and how that feeds into their pelvic floor. So sometimes with men, I've had to work a little bit higher up the chain in that mid back or like a little bit lower in the back to make sure that that area is moving well. And then also through their hip flexors as it feeds into their pelvic floor. Which again, I always tell people it's sort of like every little component here. It's like we're trying to get a 1 to 5 degree shift. So when you look at like what Allyson does, that's going to get a huge shift. And then all these little other things that we're suggesting creates the shift where you really turn the corner and get better.
Yes, I love how you mentioned the iliopsoas, that those large hip flexors are quite often an issue.
Oh yeah. I mean, I'm so lucky. I have a partner who's also a physical therapist that just like treats me to like keep me up and functioning sometimes. And he was pushing in on my hip flexor muscles and he's like, honey, you got to work on this. And I'm like, listen, I am treating patients. I am doing good. I will focus on myself, just not today. Would you just quick treat me? So, yes, those hip flexors, man.
Or some self-care.
Yeah, exactly. I know, which is like the theme of the next 2 weeks for me. And I'm like, yes, that's right. Self-care. Yes, Laura, we got to do this.
Yeah, so someone was also asking for hydrodissection for the pubic symphysis pain. Yeah, we'd have to, it just depends on your symptoms. So we'd have to evaluate you. With pubic symphysis, again, you first want to make sure is there any trauma? So no fracture and any essentially asymmetry, it's important. So sometimes it's just inflamed and irritated, and then we'd have to evaluate your whole pelvic floor sling and see what's going on. Sometimes with the pubic symphysis, it's actually the genital branch of the genital femoral nerve. Even that ilioinguinal can play a role in pubic symphysis pain. So we just have to see why. It's probably the most common time we see some pubic symphysis dysfunction or osteitis pubis is postpartum. It's most common, but sometimes it comes even with hypermobility. The patients with hypermobility can often have it as well. So yeah, we'd have to evaluate which nerves are dysfunctional. How's the pelvic floor? How are the hip abductors? And how's your actual joints? And make a treatment plan.
Yeah. So just like she was saying, it's so important with this entire treatment plan. There are so many, I always say there's more than one way to skin a cat. Again, maybe that's just a Midwest saying. But we always want to see all of these components there, and it would be just so incredible. And I think Allyson and I would be cajillionaires if we could just wave our wand and just do it, with one thing for each person. But it's that individualized plan of care that she keeps talking about, which is so, so huge. And I feel like post-COVID, it's been a little bit interesting because I have found that some patients are saying, oh, I'll just go online, I'll just Google it, I'll do something like that. And really it comes down to you need to go to a really good professional and have a really good team of highly educated professionals that can really look at every single aspect of you. If you go to a provider, just one provider, and they say they've got all of the answers and they're the only person that can fix you through surgery or something, that's definitely a red flag for me, because the people that I see have the most success are the ones that truly have a multidisciplinary team behind them who's looking at all of these different components to make them better.
Mm-hmm.
Yes.
Yeah, Laura, you would want to say to kind of our listeners out there, just about, all the wonderful things you do and really helping patients. What would you say?
Yeah. So like examples of things that I do to help patients.
Basically, like if there's just something you want to let kind of our patients know,
Yes.
what would you want them to know?
Yes. Okay. My big take home message is that, physical therapists can be such huge, amazing components. I know Allyson is a huge advocate for us, but being able to have someone who can meet with you on a weekly basis and look at things that are giving you difficulty, whether it's lifting, bending, intercourse, going to the bathroom, having a bowel movement, there are providers who all we do is figure out how to functionally make you better. And so seeking us out and being willing to put in around, I would say, at minimum 6 to 8 visits to be realistic. Usually it's longer, but being willing to put in that time with that person can help you get better. And it's so important. The injections and medication and education are all good, but there are people out here which all we do is focus on functionally how to help you move and integrate into life better. And there's always hope. And there's always something that a physical therapist can do. And if you ever hear someone say there's nothing we can do, then go find a different provider.
Love it. That is the best advice, because we do hear that there's nothing we can do.
Yes. Even people will say that they said the pain is in my head. I've reached my therapeutic capacity. I cannot tell you how many individuals I have seen where when I ask them, okay, what did your physical therapist do? And they're missing many of the components that I think should be a part of a great program. One of the biggest components that I think is missed by at least some of the providers in my area, physical therapists in my area, is a solid home exercise program. So the answer isn't always strengthening, as you know, but being able to do things to help get you better. Many times I think physical therapists create this dependent dynamic. So making sure that someone feels empowered and that they're able to make better decisions every day around their pelvic issue, I think is really, really, really huge. So never feel that you're alone. There are always people out there who are rooting for you. And if you can't find someone locally, then I highly recommend it's worth the money and the time to come to someone who's not by you to get better.
Completely agree. The home exercise program is so important because, we're trying to rehab that pelvis, right? So we always say it's like you're an iPhone. We need to reboot you, turn you off and on, reboot them. But it's that repetitive, even if it's 10 minutes a day, it's just that repetitive home exercise program that can work wonders for patients, honestly.
Yes.
That self-efficacy, it's so important. And there's one more question. Can all the nerves be affected in the pelvis at once? Yeah, they can, depending on the underlying cause, but yes, sometimes. And honestly, given that what we call central sensitization and that the nerves in the pelvis talk to one another is a good way to put it, because they crosstalk. Actually, one nerve can upregulate the adjacent nerve. So yes, a lot of times if it's been going on for a long time and there's certain underlying primary pain generators or causes, everything's hot. Yeah, all the nerves in the pelvis are just hot. So yes.
Yep, I always say the next door neighbors get agitated as well. So again, as Allyson was saying, it's important to really identify what is the culprit. And that's why it takes really good providers to identify that, because sometimes you can kind of go barking up the wrong tree. But definitely what we see, I'll even see people might have pelvic issues, but their stomach muscles are really hot. As we were saying, their hip muscles, it can really spread to their entire lower quarter.
Definitely. Well, Laura, this has been great. And thank you for
Yes.
you in Minnesota, anyone and looking for help, for sure, go see Dr. Laura. She's clearly an expert, and your entire approach is just phenomenal, really.
Thank you so much. It's been so incredible to get to chat with you today, and I just wish I could just, live right next door, because you're so incredible, and I loved reading all of the amazing papers and information, and it's so great. And I'm excited to sort of share a patient here coming up in the very near future. So I'll have to make sure she lets you know I say hello.
That sounds great. Thank you. Have a good night, everyone.
Bye.